Welcome to Retina Synthesis. I'm Dr. Carmen Pugliafito, and I'm joined today with one of our regular guests, Dr. Michael Singer of San Antonio, Texas. Michael, welcome back to Retina Synthesis.
Carmen, it's always great to be here. You run a wonderful program, and I'm always honored to be showcased on it.
Today, we're going to talk about the New Day study, which was a randomized study of the Iluvien implant. Can you tell us what the Iluvien implant is?
So it is a sustained released implant for fluocinolone, 0.18 micrograms, and it is delivered in an implant injected once in the eye. And what's important to understand is the New Day clinical trial was the opportunity to look at treatment-naive patients who are typically treated with anti-VEGF therapy and compare them to one Iluvien or fluocinolone implant that was given, and the patients were followed over time.
That's wonderful. How is the Iluvien implant delivered?
It's delivered by intravitreal injection, similar to what you would do with a anti-VEGF injection. The needle's a little bigger, 25 gauge, but it's relatively easy to master, and you can use, whatever anesthesia you typically you can use either subconjunctival or topical anesthesia. And essentially, it's a sliding mechanism, and the implant's gold. Eventually, if you're looking for it, it's pretty hard to see because it's really small, but over time, you'll see it at the vitreous base, very close to the pars plana.
So there's a corticosteroid challenge in these eyes, correct?
Absolutely. And one of the interesting things in the New Day trial, and I'll go over in great detail, typically people thought about corticosteroid challenge as being intravitreal corticosteroid challenge, but the New Day trial was really good because we had an opportunity to see how people did when they had topical difluprednate used BID as a corticosteroid challenge.
So tell us about the study design and
So
the
what
goals.
Sure. So the interesting thing is basically it's patients who, like I said, who were treatment naive for the 90% of them. They had center involving DME with a CST greater than 350 microns and BCVA between 35 and 80 letters. And essentially they couldn't have active, proliferative diabetic retinopathy. I mentioned before, they had a steroid challenge because they wanted to be on label. The label for Iluvien is a steroid challenge. So basically we gave them difluprednate, and if they were excluded, if their IOP went over 25 or had greater than 8 millimeters of increase from baseline. Those people, after they screened, you had 154 in the Iluvien arm and 152 in the aflibercept arm. Then they went through the induction phase, and in the induction phase, they got one Iluvien versus five aflibercept. Now, five aflibercept is what treatment is on label. So people may not treat that way, but that's what it is for the clinical trial. And then essentially they were watched over time to see whether or not they would need rescue therapy with aflibercept. And basically, rescue therapy was defined as CST greater than 400 or CST greater than 320 microns with 5-letter loss or 10-letter loss or loss of 5 letters at 2 consecutive visits. And when the primary endpoint was essentially the number of rescue therapies you needed over the course of the trial. The secondary endpoints was BCVA, 5, 10, 15-letter gainers, OCT changes, and a number of patients who didn't need supplemental therapy, as well as safety in terms of IOP and cataract procedures. Looking at the patients, what's interesting to note is that you had about overall an 80% completion rate, which was really nice over the course of the trial. They were pretty well, balanced between the Iluvien and aflibercept. It shouldn't be known that this is a much higher population that were phakic than the Paladin study, which I wrote on a number of years ago. And everything else was, pretty stable going forward. They all both groups were swollen, but what was important to know when we got to the results, it was interesting is when we looked at it, the number of patients who didn't need supplemental therapy was essentially equivalent between both arms at about 30%. In terms of the mean number of supplementations needed, it was numerically advantageous for fluocinolone at 2.4 versus 2.5 aflibercept. It did not meet statistical significance. However, I told you that in order to be standard of care is 5 aflibercept injections. So when you look at the total number of injections, it turns out twice as many injections were given in the aflibercept arm than in the fluocinolone arm. Looking at BCVA, it was non-inferior, which is what you wanted. But you and the patients in the aflibercept arm did pretty much the same, whether or not they were phakic or pseudophakic. If they were phakic, they gained 5 letters. If they were pseudophakic, they gained 6.7. If you were a phakic at the end of the trial in the Iluvien arm, you lost 8 letters. But if you were pseudophakic at the end of the Iluvien arm, you gained 10.3 letters. You gained more letters than anybody else. So the pseudophakic patients seem to do very well with this medicine, and this parallels other trials that have been done using corticosteroids. Looking at OCT data, when you get 5 monthly injections, you're going to get pretty darn dry. And sure enough, the beginning of the trial, they were definitely drier than the Iluvien arm. Once you had to be given as needed therapy that you weren't given aflibercept, your OCT started to seesaw up. And the people with the Iluvien arm, they kept going down and down and down. So it's kind of like the tortoise and the hare. That by the end of the study, the patients in the Iluvien arm actually had 25 microns drier than the patients in the aflibercept arm, and they were better from month 7 all the way up to month 18. Looking at treatment adverse events, there were no retinal detachments. There was one endophthalmitis in the aflibercept group, none in the Iluvien group. Cataracts is what keeps you up at night, that in IOP. The cataract numbers, essentially, there were 28% of people underwent cataract surgery of the entire population versus 7% in aflibercept. Turns out cataract happened around month 17 or 18 in the fluocinolone, which is right on when you'd expect it for steroids, less in the aflibercept group. IOP is what keeps you up at night. Overall IOP of any event was 15.6. In terms of incisional surgery, it was 1.3%, and laser surgery was 2.6. Half of them were actually PIs versus SLTs. In terms of the number of patients that needed IOP lowering medication, was 16.9% in the Iluvien group versus 3.9% in the aflibercept group. So what's really nice is that basically this is a high quality modern prospective data set that shows prospective use of steroids in combination for therapy. Really, over the 18-month period, did not have any difference in terms of mean number of supplemental injections versus aflibercept. There was a meaningful reduction number of injections versus aflibercept. There was a longer lasting interval between injections. We didn't go over that, but literally that was highly statistically significant. There was, which essentially the patients who underwent Iluvien treatment had an extra 60 days, which was really high statistically significance. There was numerically better CST over time, and a third of people were supplement free. And the cataracts and IOP are what you expect. So what's really nice about this gives you peace of mind that when you give this medicine and you treat early, you're going to have good results. And remember, we look at patients, these are treatment naive patients, right? These are patients that essentially we think about starting everybody with anti-VEGF. And we know from protocol T sub-analysis that 70% are responsive to anti-VEGF. And even in that population, when you took all comers, Iluvien held its own.
What percent of eyes underwent cataract surgery in the Iluvien group?
So in the Iluvien group, there were 28% of the entire population, and then 7% in the aflibercept group.
So this is a wonderful option for pseudophakic patients that are looking for a reduced treatment burden. Isn't that right?
Absolutely. And for people that were going to get cataract surgery anyway, right? You're a 65-year-old patient with cataracts. There's no reason not to use this. In my hands, I look at people that are over 50. Cataract surgery is the only advantage of getting older. Wisdom is way overrated, trust me. And that the reality is that if you're going to end up getting a cataract anyway, why not? It's not something to keep you up at night. So I mean, for people older patients that essentially would get cataract surgery and pseudophakic patients, they do really well. And that's what the patients population who gained the most letters in this trial.
But the Iluvien implant lasts a lot longer than 18 months, right?
It does. So the study was stopped early, for I'm not sure the reasons, but obviously there were technical reasons. But there's data showing that it can last up to 3 years. In the Paladin study, which I wrote, you had 25% of people that were rescue free up to 3 years. But because this is an 18-month study, it still showed it held its own to aflibercept.
So in treating patients with Iluvien, how often do you follow them up?
So we're going to eventually write an article for this, but essentially, um, the way I follow them up is there's a certain number of people that potentially can have an IOP spike at 1 month, and then I follow them every 3 months. Because when we look at the data, and this is data that I did, because it's now the same implant that was used for YUTIQ, we wrote articles that explain this, that basically your IOP spikes, the ones that keep you up at night over 30, fall into different buckets. So typically I'll see you at 1 month, 3 months, 6 months, 9 months, 12 months, and over time. So again, the good news is that from other clinical trials, we've shown that the fluocinolone implant doesn't increase your risk of glaucoma being optic nerve damage, even though you may have ocular hypertension, which is controlled by medication.
Do these patients develop permanent glaucoma?
No, data shows they really don't. I mean, yes, in looking at, you only had 1.3% of people who needed incisional surgery. And there was data that looked at, not in this study, but we're going to look at the upcoming analysis to look at OCTR and FL to answer that question in better detail.
So, where does Iluvien fit into your practice these days?
So it fits into my practice. I have a DME patient, and if I'm giving anti-VEGF medicine and I'm not getting anywhere, what I'll do is if I'm going to give three second generation anti-VEGFs, I'll bring them back in 2 weeks. If essentially you're not, I use 50%, but really, if you're under 50% dry, that tells me that this is really not purely VEGF mediated. It's also inflammatory mediated. Then I'll put you on Ozurdex. I'll give you one or two Ozurdex. And if it keeps recurrent edema, at that point, the patient's complaining anyway, I throw in an Iluvien and I watch patients. There are patients that are going to need supplementation with Iluvien. Remember, 75 or 60, 70% of people need supplementation. But the data shows from the Paladin study that the amount of supplementation you're going to give after the Iluvien is on board is about half of what you would give if you just were treating with anti-VEGF therapy.
So it is a part of your armamentarium, and you deliver it after you've given anti-VEGF therapy a chance.
Absolutely. Absolutely.
So where is Iluvien going in the future, do you think?
I mean, I think Illuvian, the goal is I want more and more young residents and fellows to be familiar with steroids because it is something in your option pool. It is interesting in every field of medicine, steroids is being used. Over time, I believe, there'll be other medications that'll probably deal with the inflammatory cascade. Obviously, there are a number of people that are looking at IL-6, but I think steroids isn't going away. And as long as you know when the problems are going to occur and you address them, the big elephant in the room of IOP, the rest falls into place nicely.
Well, thanks so much for discussing the New Day trial in Iluvien. This was terrific.
Carmen, I'm always thrilled to be here and thanks so much for showcasing it.